Today's lecture is about non-steroidal anti-inflammatory drugs. Okay? Now, first of all, classification of non-steroidal anti-inflammatory drugs. Now, these are classified into two groups. First of all, non-selective COX inhibitors, and second is COX-2 selective inhibitors. Now, among the non-selective COX inhibitors, Uh, these are these are the members: salicylates, propionic acid, derivatives, phenamate, aniline, pyrazolone, phenyl acetic acid, indole acetic acid, oxygen, pyrrole alkylonic acid, and miscellaneous group of drugs. These are all non-selective groups of drugs. Now, first of all, salicylates, which is further divided into acetylated group of drugs. An example is aspirin, while non-acetylated group of drugs, which I will further explain later on. Now, among the non-selective COX inhibitors, these are all the drugs. Now, the second group of drugs is COX-2 selective inhibitors. ये मैं बाद में आपको बताऊंगी. First of all, now the action mechanism of action of these all drugs. What is inflammation? Because these are anti-inflammatory drugs. So first of all, we should know about the inflammation. There may be acute or chronic inflammation which brings about immune response in the body, that is antigen antibody reaction occurs in response to any inflammation. Then next, the outcome of immune response occurs in the two ways: either foreign body is phagocytosed and it is beneficial for the host because inflammation ends up, recovery occurs, or acute inflammation can lead to chronic inflammation without resolution of the underlying injurious process. Now, it will now acute inflammation will be converted into chronic inflammation in this way, and the chronic inflammation involves release of various mediators which are not present in acute inflammatory response. For example, in the case of rheumatoid arthritis, in which chronic inflammation, because there are various mediators which are released in the chronic inflammatory process, so resulting in the pain and also destruction of bone and cartilage, causing severe disability. So the primary goal in the treatment of inflammation is first of all relief of pain, and second is arrest of tissue damaging process. Now, non-steroidal anti-inflammatory drugs, for example, aspirin, which is prototype of the of this group. Now, in the cases of acute inflammation, purpose is to release the pain, while in chronic inflammation, what is the purpose? That is arrest of tissue damaging process, which is also called anti-inflammatory action, and also automatically pain will be relieved also. Now, second group of drugs in the cases of inflammation, that is glucocorticoids. These are for the acute process of inflammation, while the chronic therapy of glucocorticoids leads to toxicity. And third group of drugs, which are DM anti-rheumatoid drugs, and use now these are all the three group of drugs. Now we are doing about the non-steroidal anti-inflammatory drugs. What are uses of non-steroidal anti-inflammatory drugs? There are four uses. First of all, analgesic. Second, anti-inflammatory. Third, antipyretic. And fourth is anti-platelet action. Now, anti-platelet action varies among different group of drugs. For example, in the new drugs, anti-inflammatory action does not occur. about the anti-inflammatory action. So it is their anti-inflammatory property which makes them most useful in the management of disorders in which pain is related to the intensity of inflammatory process. Because inflammation causes pain and pain is relieved. When inflammation recovers, then pain is also relieved. All these drugs are effective against a whole range of rheumatoid diseases. These are all such as rheumatoid arthritis, osteoarthritis, psoriatic arthritis, and arthritis as with the inflammation, bowel disease, and localized musculoskeletal syndrome. These are chronic inflammation. To suppress the pain, इसमें दो चीजें होंगी, suppress the pain and to arrest tissue damaging processes. That is analgesic action, anti-inflammatory action. Now, chemistry of non-steroidal anti-inflammatory drugs. There are some general properties about the drugs. For example, these are these organic acids. These are well absorbed. Food does not change their bioavailability. These are highly metabolized. Renal excretion is the most important route for their elimination. These are all non-steroidal anti-inflammatory drugs. These are found in synovial fluid after repeated dosing. Now the somewhat about the anti-inflammatory mechanism of action. How does anti-inflammatory action occur due to these drugs? First of all, there will be stimulus for the inflammation. Then after the stimulus, there will be disturbances occurs in the cell membrane, and the cell membrane is made up of phospholipids. When phospholipids, these are really phospholipids, these are converted into the arachidonic acid due to the release of lysosomes. Due to disturbance of cell membrane, lysosomes are released, and phospholipids, these are converted into arachidonic acid. Now, arachidonic acid further converted into leukotrienes and also various uh, mediators. These are also called eicosanoids. Now, arachidonic acid is converted in the various ways via the various enzymes. For example, when cyclooxygenase acts on the arachidonic acid, then arachidonic acid will be converted into prostaglandin, thromboxane, and prostacyclin into the three products. While via the lipooxygenase pathway, arachidonic acid will be converted into leukotrienes LTC4, D4, E4, and LTB4. Now the prostaglandin, thromboxane, and prostacyclin and leukotrienes, these are all having the same action, which is alteration of vascular permeability, bronchial constriction, and increased secretion, resulting into the bronchospasm, congestion, and mucus plugging. While LTB4, C4, D4, etc., these are also having additional action. For example, phagocyte attraction, activation, and inflammatory process is exaggerated. Thromboxane also converted into the leukocyte modulation, converting into the inflammatory process. Now, there are various drugs which act on the various steps in this pathway. For example, phospholipase, it inhibits phospholipids, and further process of inflammation will not occur. And corticosteroids, these act on this level. While cyclooxygenase, that is COX inhibitors, these act on the arachidonic acid, and arachidonic acid will not be converted into the prostaglandin, thromboxane, and prostacyclin. While lipooxygenase inhibitors, these will act on the way such as leukotrienes will not be formed and further process will not occur, while receptor level antagonists, these act on the leukotrienes and further process will not occur. So there are various pathways where various drugs act to inhibit the inflammatory processes. Now, this is the same that is this is the same that is pharmacodynamics of non-steroidal anti-inflammatory drugs, which I have told, I have said this all about this. That is inhibition of biosynthesis of prostaglandin, inflammation which causes cell damage and which acts on the cell membrane, lysosome, somal enzymes are released, arachidonic acid is then liberated, then various eicosanoids are synthesized. And what are eicosanoids? That is any group of substances which are derived from arachidonic acid, including leukotrienes, prostaglandins, thromboxane. These are all called eicosanoids. Now, that is the same which I have discussed about this. That is, two pathways are involved in the inflammatory processes via the cyclooxygenase pathway, where the non-steroidal anti-inflammatory drugs act, and another is lipoxygenase pathway. Now, another way of description is that is arachidonic acid. In the same way, COX enzymes COX-1, COX-2, these act on the arachidonic acid, convert into the prostaglandins, and prostaglandin, which resulting into the alteration of vascular permeability, bronchial constriction, increased secretion, and resulting into bronchial spasm, congestion, mucus plugging. While the arachidonic acid through the lipoxygenase pathway having the same processes, that is alteration of vascular permeability, constriction and increased secretion via the lycotrienes. The same will occur via the lycotrienes, and also additional, that is LT formation of LTB4, LTC4, LTD4, leukotrienes E4, which causes phagocytosis of neutrophils, eosinophils, monocytes, causing chemotaxis of these all white blood cells and resulting into the inflammatory processes, which is exaggerated. Now, there are two types of enzymes, COX-1 and COX-2 isoforms are introduced. So, their inhibitors are developed in the same way, that is COX-1 inhibitors, COX-2 inhibitors. Now, these are the drugs which are named as which having the mechanism of action, that is inhibition on the COX-1 enzyme and inhibition of the COX-2 enzyme, or inhibition of both the enzymes. That was about the anti-inflammatory action. Now the antiplatelet, somewhat about some words about the antiplatelet action, and it occurs via the inhibition of platelet cyclooxygenase. Now this action is, as I have told, that this action is variable among different groups of drugs. Now, first of all, most non-selective, non-steroidal anti-inflammatory drugs. These are reversible inhibitors of platelet cyclooxygenase, while aspirin is irreversible inhibitor of platelet cyclooxygenase and non-acetylated. Aspirin is acetylated salicylate, while non-acetylated salicylates don't block platelet cyclooxygenase, so having no antiplatelet action. And highly selective COX-2 inhibitors don't inhibit platelet cyclooxygenase, so having no antiplatelet action. Now, COX-2 inhibitors, these are having the efficacy of COX-2 inhibitors is equal to old non-steroidal anti-inflammatory drugs, that is salicylate group of drugs, which are converted further into the non-acetylated and acetylated groups. These are all having the same efficacy. Now, safety of GIT is more in the cases of COX-2 inhibitors, and number three, edema and hypertension increases in the case of COX-2 inhibitor drugs because there is no cardioprotective action. And number four, don't have antiplatelet effect in its usual doses. So ये सब चीजें जो है in the nutshell all known non-steroidal anti-inflammatory drugs. These are analgesic, having anti-inflammatory action, anti-pyretic action, but antiplatelet action varies because COX-2 inhibitors having no antiplatelet action and non-acetylate salicylates having no antiplatelet action. While all non-steroidal anti-inflammatory drugs are gastric irritants, except of a group of new agents, that is COX-2 inhibitors, and all are having nephrogenic action, except COX, except non-acetylated group of drugs, and all are having hepatotoxic action. Now, first of all, discussion about the aspirin. Aspirin is also called acetyl salicylic acid. Salicylic acid is simple organic acid with pKa is equal to 3, while aspirin with pKa is equal to 3.5. Now, salicylates, these are rapidly absorbed from the stomach and upper small intestine. Aspirin is absorbed as such and is rapidly hydrolyzed to acetic acid and salicylates. So, digestion absorption occurs in the same way as salicylates, as aspirin and salicylates is almost equal because it is hydrolyzed to aspirin is hydrolyzed to acetic acid and salicylate by esterases in tissues and blood. Salicylate is bound to albumin, but the binding is saturable so that unbound fraction increases as total concentration increases. So there will be effect on the half-life of the drug. So metabolic pathway for salicylate disposition becomes saturated when the total body load of salicylate exceeds 600 milligrams. Beyond this amount, increase in salicylate dosage increases the salicylate concentration. As dose of aspirin increases, salicylate elimination half-life increases from 3.5 hours to 12 to 16 hours. Alkalinization of urine increases the rate of their excretion. Now, again the same action mechanism of action of the aspirin, that is the same mechanism of action that is of the other non-steroidal anti-inflammatory drugs. Aspirin is the prototype group of drugs among the classical group of the non-steroidal anti-inflammatory drugs. Now, what is the mechanism of action of aspirin? The same actions, four actions which I have described, that is anti-inflammatory action, antipyretic, and antiplatelet action, and analgesic action. Now these all are now somewhat in the detail I will describe. First of all, anti-inflammatory action. First mechanism was the non-selective inhibition of both COX-1 and COX-2. In the case of aspirin, COX-1 enzyme is inhibited more than COX-2 enzyme. Now that anti-inflammatory action, that is inhibition of prostaglandin synthesis, arachidonic acid synthesis, this further converts into the which is further converted into the prostaglandin, prostacyclin, and thromboxane. This action is inhibited via the inhibition of COX enzyme, which I have described before. Now, second anti-inflammatory action is that is it causes interference with the chemical mediator of kallikrein system, and when this is inhibited, then this will result into the stabilization of lysosomes and inhibition of chemotaxis of polyps, macrophages, and granulocytes. And the kallikrein system is, what is the kallikrein system? That is kininogen is converted into prostaglandin synthesis via the kallikrein enzyme, and kininogen is converted into bradykinin, which is causing vasodilation, and prostaglandin synthesis, which is also causing vasodilation, and inflammatory processing is enhanced. So when this system is there is interference with this kallikrein system, then the inflammatory process will be decreased. Now these two are the mechanisms which are which are having anti-inflammatory action. This is these two processes, that is inhibition of COX enzyme and inhibition of kallikrein system. Now this is this is the mechanism of action of aspirin. Now, second action is analgesic action, that is decrease pain of mild to moderate intensity through its effect on inflammation and pain. That is peripheral pathway, peripheral action. And central action is inhibition of pain stimuli at subcortical level. And third action is antipyretic effects, that is through of inhibition in the CNS. And again, peripheral action, that is through inhibition of interleukin 1, which is released from the macrophages during inflammation. Now, fourth action is antiplatelet action. Aspirin produces prolonged bleeding time, which doubles if administration continues for a week. This is due to irreversible inhibition of platelet off. So antiplatelet effect lasts up till life of platelets, which is 8 to 10 days, and is due to irreversible inhibition of thromboxane production in platelets. So the antiplatelet effects of aspirin is having the same life as of the platelets, that is 8 to 10 days. Now, clinical uses of aspirin. First of all, mild to moderate pain of varied origin. Second, when aspirin combined with opioid analgesics for treatment of cancer pain to enhance the analgesia. And third is long-term use of aspirin at low dose is associated with a lower incidence of colon cancer. And number four, inhibits thrombosis after coronary bypass grafting due to antiplatelet action. Now, what are adverse effects of aspirin? Now, the adverse effects of the aspirin, these are explained via this graph. Relation of plasma salicylate level to pharmacodynamics and complications. Now, there are various plasma salicylate concentrations, milligram per dl, deciliter, that is 0, 10, 20, 50, 80, 110, and 160, etc. Now, the effects, useful effects of the aspirin, that is analgesic, antipyretic, antiplatelet action among the 0 to 10 level. And these actions, these are useful actions, while there are side effects which are gastric intolerance, bleeding, hypersensitivity reactions, and impaired hemostasis. These all occur when the plasma salicylate concentration is 0 to 10 deciliter, and also having useful actions that are therapeutic actions, that is analgesic, antipyretic, antiplatelet action. Now, anti-inflammatory actions are having when the level of the drug is between 10 to 50 milligram concentration milligram per deciliter. Uh, After that, when 50 to among the 50 and above that, there are the various lethal effects which occurs, which may be mild, moderate, severe, and lethal intoxication. That is central hyperventilation or tinnitus occurs when mild toxic reaction occurs. Then fever, dehydration, metabolic acidosis occurs at moderate level, and vasomotor collapse, coma, hypoprothrombinemia when severe reactions occur, and at last renal and respiratory failure can occur. Then level is above the 160 milligram per deciliter. Now, these are all the useful effects and also complications. Now, these central hyperventilation and tinnitus, these are mild effects. Then fever, dehydration, metabolic acidosis. Metabolic acidosis occurs due to accumulation of the salicylic acid, and central hyperventilation, when occurs central hyperventilation, that there is rate and depth of respiration increases, carbon dioxide will be washed out, and respiratory alkalosis will be resulting. Respiratory alkalosis will be followed by metabolic acidosis and then dehydration and fever. At last, renal and respiratory failure can occur. So, with usual dosage, gastric upset, gastric duodenal ulcers, erosive gastritis, upper GI bleeding, fecal blood loss, and also mucosal adaptation can occur through ulcers heat and blood loss decline. While with higher dose, salicylism occurs, that is, vomiting, tinnitus, decreased hearing, vertigo, and also reversible by decreasing the dose. While still larger doses of the aspirin, hyperpnea through direct effect on the medulla, and as I have told to you, respiratory alkalosis, which is followed by metabolic acidosis due to salicylate accumulation, and then respiratory depression can occur, cardiotoxicity and glucose intolerance will occur. Now, when serum uric acid increases when the dose is given 2 grams daily of aspirin, while serum uric acid decreases when dose is given 4 grams daily of aspirin. Now, these are the doses of the aspirin which are important. Contraindication in the cases of hemophilia, because there are bleeding tendencies, then frequent and mild elevation in liver enzymes can occur, then rare is hepatitis, and decreased renal functions can occur, bleeding in the cases of bleeding tendencies, then rashes and asthma due to allergic reactions, or due to the another pathway of leukotrienes will be exaggerated because COX inhibition occurs, then the other pathway will become active, and that pathway that is the of the leukotrienes that will result into the allergies, asthma, and bronchoconstriction. So with the aspirin, these all can occur. Now, it is important treatment of overdoses. That is, first of all, gastric lavage. Then second, sodium bicarbonate infusion, so that urine will be alkalinized because there is already metabolic acidosis. Increased urine output state is maintained. Then number three, hyperthermia temperature should be treated. And number four, electrolyte abnormalities, these are corrected. Now the serious toxic reactions, in the case of serious toxic reactions, ventilatory assistance is required. Sodium bicarbonate infusion, which will excrete salicylate from the body. Contraindication in the cases of hemophilia and valuable in the treatment of preeclampsia and eclampsia. Now this was all about the aspirin, and somewhat about the aspirin is that children with viral infections who are treated with aspirin, these are having increased risk of developing Reye syndrome. Reye syndrome क्या है? A rare but serious syndrome of rapid liver degeneration and encephalopathy. So in this case, so aspirin should be given with extreme care in children. Now this was all about the aspirin, and aspirin was non-selective COX inhibitor, and among the non-selective COX inhibitor, among the acetylated group of the drug. Now this was all about the aspirin. Now second group among the non-selective COX inhibitor was, and among the salicylates was that non-acetylated group. Non, that is, salicylates were divided into acetylated group, for example aspirin, and non-acetylated group. Now examples of non-acetylated salicylates are sodium salicylate, magnesium choline salicylate. Now these are all again having anti-inflammatory action, but in the cases of analgesia, these are less effective than aspirin because these inhibit COX enzymes less than that of aspirin. So preferred when cyclooxygenase inhibition is undesirable, such as in patients of asthma, bleeding tendencies, and those with renal dysfunction under close supervision. Because the some COX are inhibited less than in the case of aspirin, less effective than aspirin, and also less side effects than that of the aspirin. Less allergic reactions occur than that of aspirin, so these are preferred in the cases of asthma, bleeding tendencies, because leukotriene pathways will become less active, and that pathway was responsible for causing asthma allergic reactions, etc. So, in fact, for the renal insufficiency, these are regarded as the best. Dosage is same as that of aspirin. So that was the non-acetylated salicylates. These are result is that these are having less anti-inflammatory and less analgesic action and less side effects देन एस्पिरिन के निस्बत इसके साइड इफेक्ट्स भी कम है, इसका एंटी इन्फ्लेमेटरी एक्शन भी कम है, एनर्जेटिक एक्शन भी कम है, एलर्जिक रिएक्शन जो कि एस्पिरिन के जरिए कॉक्स इनहिबिशन के थ्रू होंगे वो इसके कम है, बिकॉज कॉक्स इनहिबिशन जो है वो कम है, ल्यूकोट्रीन जो है ल्यूकोट्रीन पाथवे जो है वो लेस एक्टिव है, सो एलर्जिक रिएक्शन जो है वो नहीं होंगे इसमें और कम होंगे. Now, COX-2 selective inhibitors of COX-2. जैसे कि we have described about the classification non-selective and selective group. Among the non-selective, salicylates and salicylates was further into acetylated and non-acetylated group of drugs. Now, this all we have discussed about. Now, the second group of drugs, that is COX-2 selective inhibitors or COX-2. COX-2 inhibitors or COX-2 selectively bind to and block the active site of the COX-2 enzyme much more effectively than that of COX-1 enzyme inhibition. ठीक है, ये COX-2 inhibitor COX-2 enzyme को ज़्यादा inhibit करते हैं. Now, what are similarities of COX-2 with classical non-steroidal anti-inflammatory drugs? There are three similarities, that is having the analgesic action, antipyretic action, and anti-inflammatory effect. These are same as that in case of COX-1 inhibition. While differences between the two are, that is, number one, antiplatelet action. No effect on antiplatelet effect application in the case of COX-2 inhibition. जब एंटीप्लेटलेट एक्शन नहीं होगा तो नो कार्डियो प्रोटेक्टिव इफेक्ट अकर बाय द COX-2. और सेकंड क्या होगा, यूजफुल इफेक्ट जीआई सेफ्टी, few GIT side effects than traditional non-steroidal anti-inflammatory drugs. तो इसीलिए आजकल जब कोई पेशेंट हो GIT जिसमें अल्सर्स या गैस्ट्राइटिस या ऐसा प्रॉब्लम हो तो उसको हम प्रेफर करेंगे कि उसको हम COX-2 inhibitors दें than that of the classical group of drugs. Now, renal toxicity, which is similar with COX-1 and COX-2 inhibition. Now, indications of COX-2 inhibition, again, that is in the cases of bone repair, when short-term use in post-op patients and those undergoing bone repair. Then, in the cases of osteoarthritis, rheumatoid arthritis, these are all chronic inflammatory processes in which COX-2 inhibitors can be given. Then, primary familial adenomatous polyposis, that is allergic reactions also. Allergic conditions, which these are involved in all these conditions. Dysmenorrhea, acute gouty arthritis, ankylosing spondylitis, acute musculoskeletal pain. Now, the COX-2 selective inhibitors, which I have been describing, so examples are siloxib, rifaximin, and valtoxib. These are having reduced risk of GI adverse effects, which was useful in the cases of GIT. Then rifaximin and validoxib. These are having increased risk of myocardial infarction and stroke. ये क्यों इसलिए होगा, because of anti-inflammatory action. The risk of arterial thrombosis is due to greater inhibitory effect of prostacyclin formation than on platelet TXA2 thromboxane formation. ये क्यों इसका इफेक्ट होगा? बिकॉज ग्रेटर इनहिबिटरी इफेक्ट जो है ये है प्रोस्टासाइक्लिन पे देन थ्रोम्बोक्सिन फॉर्मेशन पे। जो पीछे आपने जो देखा था इसका मैकेनिज्म ऑफ एक्शन जिसमें प्रोस्टासाइक्लिन प्रोस्टाग्लैंडिन थ्रोम्बोक्सिन प्रोडक्शन हो रहा था, तो इनमें प्रोस्टासाइक्लिन पे जो है इनहिबिटरी इफेक्ट ज़्यादा है देन ऑन थ्रोम्बोक्सिन। जब प्रोस्टासाइक्लिन जो है it promotes vasodilation and anti-inflammatory effect. तो प्रोस्टासाइक्लिन जो है ये यूजफुल इफेक्ट है अगेंस्ट द कार्डियक प्रोटेक्शन के लिए प्रोस्टासाइक्लिन ज़्यादा बेहतर है, और ये प्रोस्टासाइक्लिन को ज़्यादा इनहिबिट कर रहे हैं। जब वो ज़्यादा इनहिबिट होगा देन कार्डियो प्रोटेक्टिव एक्शन विल बी लॉस्ट। देन TXA2 having opposite effect because it is causing platelet aggregation। प्लेटलेट्स में से थ्रोम्बोक्सिन प्रोडक्ट जो है वो जब रिलीज होगा थ्रोम्बोक्सिन जो है वो इट विल कॉजेस प्लेटलेट्स एग्रीगेट, सो देयर विल बी नो एंटी प्लेटलेट इफेक्ट। तो इन दोनों की प्रोपोर्शन जो है इसमें जब फर्क हो जाएगा, प्रोस्टासाइक्लिन पे इनहिबिशन ज़्यादा होगी, थ्रोम्बोक्सिन पे ऑपोजिट इफेक्ट होगा, तो उससे कार्डियो प्रोटेक्टिव इफेक्ट विल बी लॉस इन द केसेस ऑफ COX-2 inhibition. Okay, now I will discuss about the other non-steroidal anti-inflammatory drugs next in the next lecture. In this lecture I have discussed about the non-selective COX inhibitors. Among them salicylate group of drugs which was further divided into acetylated and non-acetylated groups. And acetylated group, that is example is ethylene, and non-acetylated group that was discussed, and other group of drugs that are included in the non-selective, these are propionic acid derivatives, phenamates, aniline, pyrazolone, phenyl acetic acid, indole acetic acid, oxycam, pyrrole alkalonic acid, miscellaneous group of drugs. This will all be discussed in the next lecture.
I'm sorry to interrupt you, just 3 minutes left.
Hello?
Just 3 minutes left, ma'am.
हाँ जी, बस ये टॉपिक खत्म हो गया है, ठीक है, ऑलमोस्ट तकरीबन एंड ही हो गया, ठीक है। थैंक यू, लेक्चर इज एंडेड।
Okay, ma'am.
ठीक,